Hello everybody, it's Dr. Ryan here, board certified specialist internist. Thanks for joining me even as we break down pleural effusion this morning. If you haven't yet subscribed, what are you waiting for? Let's go through 30 causes of pleural effusion. Quick fire, rapid review. Alright, the first point of departure, guys, is to do your x-ray and to ascertain the presence of pleural effusion clinically and radiologically. Pleural effusion is basically the presence of fluid in the pleural space. Now, if you have more than about 200 mils of fluid, you can detect it on a lateral decubitus film. If you have more than 500 mils, you can easily see that on a PA erect chest x-ray. So once you do your pleural tap, you want to ascertain whether you're dealing with a transudate or an exudate, right? And the main distinguishing features is you got to look at a ratio. The pleural fluid protein to the serum protein ratio of above 0.5, pleural fluid LDH to serum LDH ratio of above 0.6, and pleural fluid LDH being 2/3 at least of the upper limit of normal of serum LDH. This is what we call Light's criteria, and that represents the first departure point of saying transudate. So if these values, if the pleural fluid protein to serum protein ratio is less than 0.5, pleural fluid LDH to serum LDH less than 0.6, pleural fluid less than 2/3 upper limit of normal for serum LDH, it's a transudate. If not so, it's an exudate, right? Transudates are further partitioned into hydrostatic, not due to increased hydrostatic pressure, diminished oncotic pressure, or diaphragmatic issues. Exudates further stratified into whether it's infectious or non-infectious, right? Excuse me. So, by and large, the most common cause of transudate from an increased hydrostatic pressure, congestive heart failure, right? Interestingly enough, most of the effusions we see in heart failure are right-sided effusions, and the thinking behind that is because most patients with heart failure experience palpitations when they sleep. They tend to sleep on their right side, and that causes dependent accumulation of fluid, on the right side. Then constrictive pericarditis is another cause. Superior vena cava syndrome. Remember, a big tip-off for constrictive pericarditis is ascites out of keeping with peripheral edema. Superior vena cava syndrome, atelectasis, right? Pneumonectomy and trapped lung syndrome. Causes of transudate on the basis of having a diminished oncotic pressure. Cirrhosis often causes hypoalbuminemia, right? Nephrotic syndrome, also hypoalbuminemia. Protein losing enteropathy, also hypoalbuminemia, and mixed edema in the setting of hypothyroidism. Diaphragmatic issues, things like hepatic hydrothorax, could be related to peritoneal dialysis or urinothorax, right? So if you're dealing with the exudate, we stratify that in infectious versus non-infectious. Infectious causes, look, it could be a parapneumonic effusion. It could be something common in our setting, tuberculosis, pleuritis. You also want to send that fluid off for acidophilus bacilli and gene expert testing. It could be a subphrenic abscess. Non-infectious is a whole bucket load of causes, guys. Malignancy, especially in a patient who's a smoker, right? Remember, COPD per se does not give you a pleural effusion. If you see a pleural effusion in a patient who has a long-standing smoking history with clinical stigmata of COPD, you got to be thinking either they have bronchiectasis, a lung abscess, or they have a malignancy happening, right? Pulmonary embolus, collagen vascular disease, right, especially lupus, GI disease, hemothorax, chylothorax, right? One of the rare causes of chylothorax is lymphangioliomyomatosis, which can be a standalone disease or fit into another complex example, the tuberous sclerosis complex, post-cardiac injury syndrome, post-coronary artery bypass graft, medication-induced, radiation-induced asbestosis, uremia in the setting of chronic kidney disease, Meg syndrome, which is interestingly left pleural effusion in association with an ovarian fibroma, and yellow nail syndrome. I also want to take some time to talk about pride, right? The Bible tells us that if you abase yourself, God will lift you up, right? That God resists the proud person, right? And an easy acronym for pride to be able to recognize that in our lives. P is for personal ambition, right? You do everything just for your benefit. You don't consider the needs and the rights of others. R is reliance on self. You don't rely on God. You don't pray. I is inflated self-esteem. You think too much of yourself. D is delusions of grandeur, where you think you are better than everybody else. E is entitlement, right? And it's a prayer of my heart that we're able to do an introspection. And if indeed we do have these features of pride, that we will humble ourselves before the Lord, ask for forgiveness, and always consider other people as being more significant and more important than ourselves. God bless you, everybody. Hope you enjoyed this video. I'll see you soon with another handy, rapid review in internal medicine. You take care.